So welcome everyone to Zarn's webinar series. This is a set of lunch hour series that runs about 30 to 45 minutes to get you more in touch with what's going on in the industry. And today we have Dr. Keith Matheny here joining us with the topic, how to drive cost savings in this back to new normal world. Thank you for joining us today. And Laura Dennis, our Vice President of Sales and Marketing, will be doing a slight introduction. Just some ground rules. This is a webinar, so within the chat function, you can have conversations and ask me questions if you're having trouble with hearing any of the sound. You can also put questions in the Q&A area that's over here. We will take those questions and Dr. Matheny will try to answer as many as he can during the session. Those we can't get to, we will try and get back to you at the end of the webinar when we send your recording within the next week. Help on Zarn Systems is always available at zarntech.com. Let's get into the webinar. Laura, are you ready to introduce Dr. Matheny?
I'm more than happy to. Yes, Dr. Keith Matheny is a Vanderbilt trained otolaryngologist down in North Dallas. He's been a longtime Zoran friend, and while he maintains a clinical practice, which is one of the reasons why we squeezed this in his time during this this lunch hour here, he also has a lot of interest in clinical research as well as outside research interests and product development in other areas. As we'll learn today about addressing the business aspects of the ENT practice, Dr. Matheny is the founder and chairman of US ENT, which is a GPO or group purchasing organization focused on helping ear, nose, and throat practices reduce their costs and improve their practice revenue and their workflow. So I'm looking forward for us having all of his knowledge and expertise on the call today.
Thank you, Laura. Thank you, Ramade. So I'm honored to be here to talk about these topics, and still being a practicing physician, obviously I'm shoulder to shoulder with my colleagues on this challenging year, figuring out how to get our businesses back to a healthier state. As we learned early on when many of us shut our practices down, that pricing has never mattered more and business efficiency has never mattered more, and just our general business operations are really important for us to focus on. So a little bit more about me. I'm about 20 years out of Vanderbilt, and I joined here in North Dallas two fantastic physicians at that time. My first week of practice back then, I had 50 new patients. I would be happy for that right now, trust me. But back then I had 50 new patients just from their overflow. So obviously they were doing a lot of things right. But that being said, I talk about those days fondly as they were busy in spite of their business infrastructure, despite of their setup. At that time, they were in an old office, 30 years old at that time, by a dying hospital. Physician staff were moving away, the referral networks were moving away. The staff in our office was a mixture of 3 different practices that had merged, and so a lot of the staff members were more focused on interpersonal conflicts than on patient care. We had paper charts and a very rudimentary scheduling and billing software. We had no internet presence, all those things. And actually our hearing aid and allergy departments were losing money. So it was actually costing us to have those ancillaries. And so really with no particular training, but certain interest in getting our business healthier, I took over business operations. And by the time that, by about 5 years later, we had moved out of that initial office by that hospital into 3 different locations, modern offices with different referral networks and playing different political or utilizing different political strategies to gain new patient referrals. We had gone paperless. We had implemented mid-level providers. We had made hearing aid and allergy profit centers for our practice. We had gotten involved in aesthetics and sleep and ambulatory surgery centers and lots of different adjacencies. And so I like to think about that time as while we were busy before, in spite of our surroundings, we became much busier because of them. And it is around that time that Ms. Jennifer Owens, who's my colleague at USENT now, joined our practice as our administrator. And since we had had success in many different aspects of our practice, other practices here in Dallas-Fort Worth started reaching out to us for advice. How do you bring on a PA? How do you start an allergy department? How do you make your hearing aid business more profitable? How do you tighten up revenue cycle? And so we formed a consulting company, which still exists today. And over that 12 years, we've managed all or parts of 5 different practices in addition to our own. But it grew into a larger concept several years ago. And along with the advent of moving balloon sinuplasty, moving primarily rhinology procedures into the office, it became evident that our costs for practicing ENT continued to rise. The upside of the transition of procedures into the office is physicians have more opportunity for reimbursement. The downside is we now pay the bill for the supplies, whereas our acute care settings, our hospitals and ASCs used to pay those. And so the consulting company grew into something larger, an organization called a GPO, and that is a formal legal entity. The acronym stands for Group Purchasing Organization. And what that is, in a nutshell, we take advantage of a large national membership to negotiate better pricing on all of these expensive supplies that it takes to practice ENT in a modern office. So sinus balloons and hearing aids and allergy supplies and endoscopy towers and those types of things. So that's where we stand today. And Zoran is a principal partner in that GPO. In fact, Laura and I were early partners together, one of the first companies to partner with USENT, the GPO. And so that relationship has been very positive and fruitful. We've learned a lot, and that's what we want to present today as we've been in and out of offices all over the country. So we want to identify cost-saving opportunities that you can employ today, things that you're already doing, ways that we can do things more efficiently. But I do want to touch for a few moments on additional revenue streams that practices may not be taking advantage of. And obviously, this is a very quick introductory conversation. Each of the points probably could be their own 30-minute discussion. But I'll try to hit on all of those, and it's very casual. So if there are any questions or comments, we'd love to entertain those. Next slide, please. Okay, so first with the cost-saving opportunities. You can go on ahead to the next one. All right, so obviously we all had to tighten the belts and really look inward in our practices back in the spring once this COVID thing that we heard about early on proved to be a real phenomenon. It's something that we, especially as otolaryngologists and rhinologists like myself, had to really be concerned about, whether it was safe to practice our craft, or were we spreading the virus faster than just the normal routes. So in our practice here in Dallas, we already had been doing a pretty good job of paying attention to these things, but we've really paid close attention to several different areas. The pricing of all the different products that we're using day in, day out. Paying attention to our inventory, paying attention to our staffing. And we'll talk specifically what I mean by that in several different areas. We paid a lot of attention to how we were scheduling, what types of patients and who was prioritizing, who was not. Someone that we could put off a few weeks. How we were utilizing our various clinic in the spaces within each of those clinics, and then opportunities for outsourcing. So these are all areas of interest and things that, especially now, these are always important, but especially now as we all try to recover from this year of decreased revenue are that much more important. So next slide. So for example, most of us, our practice included, really had not paid much attention to the price of goods, our balloons and our hearing aids. We typically developed very strong relationships with the sales representatives from each of these suppliers and trusted the technology and trusted those relationships and kind of left it up to them to determine our pricing. That's probably most akin to going to buy a new car and walking on the car lot and just agreeing to the sticker price, or in some cases even offering to pay higher than sticker price. What I've learned in building the GPO and negotiating these direct contracts is that our supplier colleagues are very happy to work with us, all the more now during these COVID times. And so it is absolutely worth, even as an individual practice, talking to your suppliers, whichever balloon vendor you use, whoever your preferred 2 or 3 hearing aid suppliers are, looking at the pricing that you're paying, asking if there's opportunities to improve that pricing. I have found the suppliers are very willing to work with us as physicians for a simple commitment of primarily utilizing their technology. So those are very fair deals. This table we have here is an example of what we can accomplish in mass as otolaryngologists when we unite and team up to negotiate contracts. So when several hundred of us get together, these are examples of the discounts that we can get. So balloon pricing obviously improves because we're looking now at a much larger number of cases, combining our practice numbers together. Allergy and hearing, of course. But where it seems to make the most impact are things that we often don't think about. All of us, we can probably in our minds conjure up our average balloon price or how much we're paying for a Propel stent or this or that. But we have found, as we've been in so many different practices around the country through the GPO, that a huge area of savings is in med-surg, what we call med-surg. So many of us interface with large distributors such as McKesson or Henry Schein or Medline. And we get all manner of supplies from these companies. Everything as simple as gauze and tongue depressors and otoscope covers and those types of things, all the way up to our exam chairs, our microscopes, our SMR cabinets. And if we are overpaying on other supplies, this is to a much more maximum degree that we're overpaying for these. And so what we've been able to do in our GPO, for example, is bring 30 to 40% savings. We have one practice that we are saving them 70% off of what they were paying for these types of items. So just thousands and thousands of dollars per year. Again, that always matters, but it really matters this year. Even little things like office supplies. So all of those things are worth examining. Okay, next slide, please.
So at this juncture, Dr. Matheny, we just wanted to announce that we do have a poll ready for all of our attendees to participate in, well, except for hosts and panelists, I guess. So not me, I was gonna vote. What are you most interested in hearing about? You should be able to click more than one. and that will give us a little bit of real-time information on the fly about what we might focus on if there's additional time here once we get through a couple more of these slides of this presentation. All right, thanks, Dr. Matheny. We'll keep on going.
Yeah, perfect, Laura. Thank you. All right, Ramade, we'll move on to the next slide then while people are taking the poll. Okay, so we've talked about cost savings, and again, there are so many things to talk about: how to optimally schedule your clinic, how to optimally staff it, how to improve the flow in audiology and allergy. I mean, again, each of these could be their own webinar. But we want to make sure we highlight a few new revenue streams that we, as we've gotten to know other practices around the country, see many practices not really maximizing, not really taking advantage of. Let's go on to the next slide, please. So these opportunities include radiology, audiology, of course, allergy, of course, sleep. We'll spend a lot of time talking about that because that's something that we all feel like we do, but I would submit that we could all do it much more efficiently, take better care of our sleep patients, and also generate some revenue for our practice in doing so. And then just the general concept of office procedures, which has grown so much since 2011 when we first started to do balloon sinuplasty in the office. And obviously we had been doing myringotomy tubes and endoscopy for 20 years before that in the office. And then finally, how to optimize the use of mid-level providers. Next slide, please. Okay, so I wanted to drill down on sleep first. So if you had asked me even 5 years ago, Keith, do you do sleep in your practice? And I would have said, absolutely. It's one of the emphases of my practice, in fact. And that is true in a sense, because anybody with sleep disordered breathing, snoring, what have you, usually their spouse is dragging them in by the shirt tail to come see the ENT to get their snoring fixed. But how we used to do sleep, at least in our practice and what we found in most practices around the country, is we would evaluate the patient, look at their upper airway anatomy, perhaps do endoscopy, those types of things, and then order a sleep study, which was done somewhere else. Even with the advent of home sleep testing, many of us as otolaryngologists even outsource that to a sleep physician. And I've found in my own practice and certainly around the country that that's often the last time we see that patient. Perhaps if we're lucky, we get to interpret the sleep study and discuss options with the patient and then write a prescription for CPAP. As we know, compliance with that is less than optimal, to say the least. And so many of those patients are lost to follow-up. And I feel like that's a missed opportunity from a clinical care perspective. So now how we do sleep is quite distinct. 5 years ago, we implemented home sleep testing in our practice. I specifically used the WatchPat technology from Itamar Medical, which is, in my opinion, one of the premier, if not the premier, home sleep test on the market. So we purchased machines. We made the capital purchase back then 5 years ago, and immediately, instead of outsourcing that patient to a sleep lab or a sleep physician that had home sleep testing, we were able to do the testing. So now when we see a sleep patient, we do the initial E&M, I order the sleep study. There is after the prior auth, which takes a day or two in many cases, there's a second visit, the nurse visit, where the patient comes into my office to pick up the technology and get oriented on how to use it. It's simple. This particular technology usually only needs 1 night of measurement. So they bring the device back the very next day. The data is in the device itself. There's a memory card in the wristband part of the WatchPat. I'm able then to, so we have the technical component of the test after the nursing visit, then I'm able in many cases to do the interpretation myself, even though I am not personally board certified in sleep. So there are some insurances, and Medicare would be the most notable, that I cannot do the interpretation, but in many cases I can. Then I have the follow-up discussion with the patient on a true clinic appointment. Usually it's a 99214, just because I spend a lot of time going through the test and going through the treatment options. And then we're off to the races, whatever they're going to have done, whether I prescribe the CPAP, or in years past, I would refer out for dental appliances in some cases, or if something surgical was indicated. Well, 2 or 3 years ago, we implemented a second phase of this sleep program, which has really, really taken our patient care to the next level, and quite frankly, our revenue opportunity too. So we now bring into our office a sleep dentist. So a professional that in our market here in Dallas-Fort Worth has been in practice 25 years, has in-depth knowledge of all of the sleep appliances on the market. And so when I feel that a patient, and my partners and I feel that a patient is a candidate for a dental appliance, so these would be mostly the mild OSA patients with relative macroglossia, we will again keep the patient in our physical office and have them see the dentist. Now, because we are and I don't want to get off into too much of the tangent, but because we are the ones as physicians prescribing this dental appliance, this can be run through a patient's health insurance, which really benefits them from a cost standpoint. Plus, I have the quality control of having the dentist just 5 rooms down from my own exam rooms. And the patient then in this scenario it's a 2-step process, which is necessary for us to be able to bill this from an insurance standpoint. So it's fit one day, manufactured and delivered a second day by the dentist. The dentist in our practice does all of the troubleshooting to minimize any dental shifting or TMJ pain, etc. And there's a high degree of satisfaction. What you have in front of you on the slide, and Ramade, I'm still seeing the poll question, so I don't know if that's just me or it may be blocking the view of our attendees.
You should be able to X out of it. That's
Good.
right.
Okay, good.
I was able to.
Yeah,
do
I just did, just making sure everybody did.
Yep.
So here are the numbers for our practice. Okay, so at this time, this is 2019 numbers. We had 4 physicians then, we've gone up to 5 now. So these are our real numbers. So we net over $90,000 while we're doing the most important part of our job, meaning when we see the sleep patient, we're shepherding them through the entire process to make sure that they are adequately treated and compliant. And this doesn't even account for the majority of patients that I still send for AutoPAP or other types of CPAP. Okay, just in the interest of time, let's move on to the next slide, and I'm sure there'll be questions about this. Happy to revisit them. Yeah, so I'm looking at the poll results, and we'll definitely spend time talking about optimizing our sinus care for sure. Thank you. Okay, so obviously Zoran is coordinating this call. And I would talk about radiology though, even if they weren't. So as Laura knows, we put our scanner in our office in October of 2017. And the very next day, and I'd been hesitant, we had a couple different models. We actually shared a CT scanner with 4 other ENT practices in our neighborhood, and it was mobile. So it was brought in our case, every Monday for years. We did that. And felt like we were being progressive. But Mondays are an OR day for me. So I was never actually there to see a patient, have them scanned and review it with them at the same time. So when we put our scanner in October of 17, the very next day, I wondered what the heck we did without it. Because I immediately saw the elevation of patient care by having in-office radiology. So now, and I'm fortunate to practice in an area around a lot of corporate headquarters. And so there are a lot of busy people. My patients are busy people. They don't have time to come to my office 3 or 4 times. If their administrative assistant has scheduled them time to come see the physician, I need to do my darndest to make sure that I can evaluate everything I possibly can and have a treatment plan during that first visit. The CT scan is one of the ways that affords us this ability. So now when I see a new patient, if a CT is indicated, my staff will very quickly obtain the prior authorization. We'll march them down the hall. I'm able to obtain that scan. It literally takes less than 20 seconds to do the scan, yet it's extremely high resolution. I'm able to use these scans in any image guidance system that I've used over the years, the Trudy and the Scopus and the Fiagon, and even back in the Stryker ProFest days, the scan is more than adequate. It's actually perfect for navigation. But there, 20 seconds later, I'm able to review with the patient in a triplanar view what's going on with them and what our treatment options are. We immediately, so this is 4 years ago, and have sustained an uptick in allergy testing, patient scheduling sinus surgery, whether it's in the hospital ASC or whether it's an office procedure, simply because, kind of like sleep, we now at the first visit have all of the information necessary for us to make a clinical decision. How it used to be, as we all know, I would see a new patient, order a CT, they would have that on another day. They would have to be scheduled to come see me yet a third day to actually look at it. And then another day we would do the intervention. So now we've really minimized the amount of patients that were kind of lost to that process by having in-office CT. Now we hear this, my team at USENT and I hear this almost every day. Well, a CT scan is sure nice and it's a luxury, but it's expensive and we don't make any money on it, or we lose money on it. And I know there are nuances in different states that many states you can't do in-office CT, and many payers don't pay for it. But these again are our real numbers from 2019, even accounting for the fact that we haven't quite paid off our note on it. We have a 5-year note, so we'll finish that in 2022. Even after paying our monthly service, this is what we net, this $168,000 last year amongst the 4 of us and our 2 PAs and other people that may be ordering them. Our average reimbursement for the global bill, so the technical component of the CT plus our interpretation, the professional component, is about $145. And that even accounts for Medicare. Medicare does cover this, traditional Medicare, not necessarily the Advantage plans and other things, cover this, as well as many payers. Aetna and Cigna, or no, sorry, Aetna does, Cigna and Humana do not cover this. But in those patients, I still view this as a worthwhile, simply from a patient flow standpoint, it's a worthwhile endeavor to get the CT scan, even if I'm not going to be able to directly bill, simply because of the ability to take care of that patient that day and have a treatment plan. So for us, at that $145 per scan average, after our 21st scan each month, we are making revenue. That covers our debt service for the scanner. Okay, I'm sure there'll be some questions about that in the prior auth process, but it's very simple in many cases. It's literally just going to the payer website and filling out a questionnaire, CPT code, prior treatment, and other symptoms associated with the ICD-10 code that we actually listed to obtain the scan. Okay.
And I'll just to pop in for a moment, I did talk to Dr. Matheny's billing and prior authorization person. And what Dr. Matheny says is it's really not a big deal, but for those who do have staff, or if any staff are on this call right now, I know that, you have reduced staff right now. You have people out with COVID. You have people that you haven't brought back because you can't afford it. And yes, it is something you have to work into the workflow, but it is possible. So it's kind of a both and situation. So, Dr. Matheny as a clinician just wants it done, and then the office staff has to go and figure it out. And, even in this environment, they were able to do so and continue to do that prior authorization, even on the same day as seeing a new patient or an existing patient who's coming in for new issues, which of course we know is coded slightly differently. Just my.
As a takeoff of that, Laura, good point. We had the luxury of a radiology tech, a licensed tech that would do these scans for us. And she is not back with us after we did our furloughs and brought people back. She's a wonderful person, but was a luxury, and we just didn't feel like we could afford her, quite candidly. So that being said, you have to check each state's rules, but in general, we as physicians or a licensed radiology tech have to do the scan. It's still worth it. It's so quick, and you're already standing there to review the exam with the patient anyway. I have not found that to be an impedance in my clinic flow at all.
That's also a good point about who's operating the system as well. Yes, thank you. It's a good point.
Yeah. Okay, well, we're running short on time, but I did want to just mention, the mid-level provider option. That's something that we have worked in various models for about 13 or 14 years in our practice, and we feel like we really have it dialed in. In our practice, just very briefly, the way I utilize my physician assistant, he is really my scribe. The best description is he's like having a senior resident, if we think back to our training days, with me at all times. So like this morning, he has his own parallel clinic to mine, and he does a lot of the follow-ups, the allergy follow-ups, the sleep follow-ups, the acid reflux, those types of things, annual hearing checks, plus all of my post-op appointments. But we learned the hard way, the only way patients are happy to see a mid-level provider, in my humble opinion, is if they meet them at the initial appointment. So the way my clinic is now, my clinics are all new patients, results reviews like thyroid ultrasound reviews or something, and procedures. But my PA meets all of my new patients at the new patient appointment. He'll be the first one in there. He's the one that gets all the information, makes sure all the paperwork is scanned in, everything else, and actually types the better part of my clinic note for me. So he is my scribe, but I'm able to go in there right after that with all that information, just like our attendings did during training. Visit with the patient, socialize, focus in on the key pertinent clinical details, and wrap up that appointment. And that patient feels like they saw me, and they did. But my PA did the lion's share of that visit, and certainly the documentation. And then I just have to go tweak the chart and finalize it and sign it. Simultaneous, when he's bopping in and out of my new patient rooms, he is seeing follow-up patients from prior new patients that feel like he was part of the initial evaluation and the treatment plan. And so I get very little blowback now for patients following up with my PA. So that essentially clones myself. That allows me in every clinic to be almost two of myself. And certainly it lets me use my physician time much more efficiently. There's obviously other ancillary benefits. I mean, we have our PAs taking first call, so they're answering a lot of the simple questions from our patients. We cover 7 different practices, so it's quite busy. They a lot of times will assist us in the OR. They absolutely assist us in all of our office procedures, on and on. So there's so many primary and ancillary benefits to mid-level providers. The last few topics to mention, Ramana, if you'll just throw the last slide up and then we can entertain any questions. Just there are even still further corners of your practice that you can look at for either cost saving opportunities or new revenue streams. Just off the top of my head, it's worth talking to your med mal provider. Ours here in Texas gave us very nice discounts for our decades of good behavior, but also having that long relationship with them. They wanted to keep our business during these challenging times. Opportunities for clinical research. One of my other lives is I run a device company. And industry is always looking for good community physicians to study their new techniques and technology in pharmaceuticals. So those can be fun to participate in for sure, but also additional sources of revenue for a practice, and many, many more things. But that's probably enough of me talking about all this just to whet everybody's appetite. And again, if there are topics that we feel like are worth drilling down further, I'm sure subsequent webinars we can focus just on individual topics. But at this point, I'll entertain any questions we might have, and let us all get back to work. I'm sure I'll have patients in rooms here momentarily too. So Laura, Aramide, any questions from the audience?
None from the audience at this time. Laura, I think you might have a couple that you have for Dr. Matheny. Otherwise, it seems like you.
Yeah, just one question. Maybe you could speak to briefly driving your balloon sinuplasty revenue and how you're able to do that with having that CT now in the office, and how you work with your patients, and how sometimes you even don't even worry about that CT reimbursement. Maybe if you.
Yeah, I'm glad you brought that up, because I do want to highlight one thing I neglected to mention, Laura, is some recent coding and reimbursement wins. I mean, just as literally within the last week, that we can all look forward to in 2021. But yes, the topic of the CT, when I have a Humana patient, I don't bat an eye that I know I'm not going to be paid for that CT, because I have such confidence in the workflow now. If I can walk the patient down the hall, do their CT, review it, I know there's a high likelihood that that patient will follow through with our treatment plan, whether it's balloon sinuplasty or whatever we decide to do together. Now, speaking of the balloon, in 2011, when we all fumbled our way through learning how to do these office procedures that now are so second nature to all of us with anesthesia techniques and things like that, there really have been, over the last year to 18 months, and like I said, some things just within the last week, that I've been able to layer on to traditional balloon surgery, again, for increased revenue in my practice, but I would argue far superior patient care too, because they're in our practice and not going to the hospital. So I think most of us know these numbers, but every patient that we treat in our office, certainly awake, we are literally canceling the facility fee. Now, I'm not talking about those of us that have JCAHO accredited operating rooms in their office. So I'm talking about someone like me that just treats patients in a procedure room, just a glorified exam room. When we do cases, and I now for the last year or 18 months or so have an anesthesiologist that comes in and does sedation in some settings, so I can do septoplasty, ethmoidectomy, those types of things in conjunction with balloon sinuplasty, that patient is saving a fortune. Not that we care too much about the insurance companies, but they're also saving a fortune to the tune of $24,000, $25,000 facility fees for hospitals, and every bit of $11,000, $12,000 facility fees for ASCs. So the payer and the patient, who usually has some percent responsibility for those numbers, saves that money. And especially in these times of COVID, I have found this year patients are not hesitant to have office procedures, but they are somewhat hesitant to go, especially into a hospital setting, for fear of being exposed to things there. So I feel like we are also able to provide a higher level of care in our office doing that. Now, over the years, especially the last couple years, in conjunction with my balloon sinuplasty in many patients, I have started to use Propel stents in the office. We studied this in our practice 7 or 8 years ago, just from a feasibility standpoint, but the reimbursement, the economics didn't make sense back then. But now they really do. So I don't want to talk about one specific supplier, but Intersect is kind of a standalone where nobody else has technology like that. Using Propel stent technology in conjunction with balloons, As many of you are aware, the reimbursement over the last year has really improved. So from a physician standpoint, we actually receive some compensation on top of the price of our stents, especially the stent price through the US ENT program. And then the Sinuva implant is another one. The reimbursement on those, simply because we are now paid on those implants like they're a pharmaceutical, which they are, but I mean, we're now paid by the dose. And so the Sinuva implant, which has 3 to 4 times the amount of mometasone that the Propel does, we're therefore compensated at a much higher rate. So those are other, I encourage you to talk to your Intersect rep about opportunities like that. I know not every state can use Propel in the office, but with United Healthcare, for instance, all 50 states have access to that and good reimbursement. The codes I alluded to that came out last week were twofold. One was having a formal code for the Eustachian tube balloon dilation procedure. Many of us have found that helpful in our very recalcitrant patients that we've put many tubes in over the years. Obviously, it's indicated for adults only at this time. But starting January 1st, Medicare actually has just published a fee schedule for that, and we expect the other payers to follow suit, hopefully within a few quarters. So that's a new procedure that we can do in conjunction with balloon sinuplasty or standalone. And then also Stryker, the Spirox Latera implant, received its standalone code last week. And CMS published that reimbursement schedule. So I encourage you to talk to your Stryker reps about those numbers. But now that's a procedure that we have confidence in reimbursement. We don't have to worry about using unlisted codes, or I know some of our colleagues have used the 30465 with a little bit of nervousness, whether that truly was the appropriate code or not. So those types of things, again, the more we treat patients in the office, I believe we are providing superior, safer care for them, but it is also an opportunity for us to generate some more revenue for our practice. And after all, you know, we are not for profit. And I think the insurance companies have taken that into account, and they realize that the whole system is saving money while we treat patients in our office. And so I'm a proponent of us embracing that. Laura, did that cover your topic enough about
Yes, thank you so much. Yes,
willing to
thank
do
you.
scans even? Okay.
There was actually a comment, Dr. Matheny. There was a veterinarian on the call, and he did offer that for their vet cat, they charge $850 up to $1,200 for their CT scans. So
Yeah.
just a sound bite.
Yeah. That's why he's the smart one going into veterinary medicine.
I was just going to comment something along those lines. Yes.
Rather than human medicine, right?
No insurance.
That's a whole nother webinar, Laura. That's a whole different one.
So
yes.
The wonderful,
it's so great to hear from you.
So the great thing about this webinar is the intent is to build best practices as we navigate through this new normal. Dr. Matheny, thank you for your time this afternoon. We don't have any questions in the Q&A, but of course, if you have additional questions that you would like to have Dr. Matheny shed some light on, or additional best practices, please send a message to info@xarentech.com. We're more than happy to take those forward. And we look forward to having you join us next week for our next webinar. Check it out on LinkedIn, and we'll connect with you soon. Thanks for joining us this afternoon. Have a great day.
Thank you very much.